Yeah, great. And maybe I can introduce you if somebody doesn't know you. And again, we are very happy to have you here, and thank you for taking the time. And it's a pleasure and an honor for us to have you here presenting your research topic. It's a very trendy and important research topic. Yeah, Dr. Moazami, he's a cardiothoracic surgeon. He's professor of cardiothoracic surgery, and he's also head of the Heart and Lung Transplantation Department and Mechanical Circulatory Support Department at the New York University, the NYU Lagoon Health. And he was actually one of the pioneers in the world and in the United States with this specific research topic. And this specific, it's actually not research anymore. It's actually being done in humans already. So we are happy to have you here, and we are pretty much looking forward to listening to your talk.
Thank you, Mateo. Thank you for the introduction, and good afternoon to all of you in Germany. So it's very interesting. I just want to kind of make a quick comment about what you said, and that is that as you guys go through your career development, you will recognize that, you know, that the greatest thing about medicine in general, but cardiothoracic surgery, is that it's a very dynamic field. And sometimes you set out your life in a different way, and then you evolve into something else. So in fact, for xenotransplantation, I was never a big xenotransplant person, you know, and I was always sold on the idea that xenotransplantation will never really become a clinical reality because of all the hurdles that there exist with rejection of a xenotransplanted organ. And most of my focus really early in my career was in mechanical circulatory support, LVAD development, and studies and trials of LVADs. Then as I transitioned to NYU, a lot of the focus went into heart transplantation and how we can grow heart transplantation. You know, and out of that, you know, we did some studies with hepatitis C organ donors. We did some work with DCD heart transplantation. And most recently, again, you know, sometimes you got to just be at the right place at the right time, is this concept of xenotransplantation and really where this is going to be in the future. And that kind of led me to think a lot about, you know, where we are and where we can head. And a lot of the research work that was done in xenotransplantation is really to the credit of people who stuck with the field and did these very difficult experimentation in animal models, and they get the bulk of the credit for that. And I really came in at the tail end of it, where we started working on the potential for clinical application into humans. So that's what I'm going to try to get to you guys and explain over the next, hopefully 40 minutes or so. So I think if you kind of look at it, and again, this data is specific to the United States, so I apologize that I don't have the European data, but the data really reflects what we see worldwide, which is a slide like this, where you look at the total number of patients, in this case in the United States, being listed for heart transplant, for organ transplantation. This includes everybody, which is about 115,000 a year. And then you look at the total number of transplants which is about 34,000. So at any given time, really, if you look at the number of people on the wait list for organ transplant compared to the ones that actually get transplanted, only about a third of people get transplanted. And this discrepancy between the number of organs available and the number of people waiting for transplant continues to grow. So even in 2022, if you look at the numbers, the United Network of Organ Sharing, which is an organization in the United States that manages the entire network of all organ transplants, and they were kind of like bragging about the fact that, you know, this year, the last year in 2022, was the largest number of transplanted organs that was ever done. That discrepancy between the number of people waiting and dying on the transplant lists continues to, in fact, exist. And the concept of xenotransplantation really was born out of that necessity, and continues to be attractive because of that, because that there is still going to be a significant discrepancy between the number of people waiting for organs and the number of organs available. So the concept of xenotransplantation, of course, is not something new, right? It extends into Greek mythology. This is on the left, a picture of Icarus, whose father built wings of wax and warned him not to fly too high near the sun. However, they were able to fly, and of course, his wings melted and he fell. And even in modern times, I mean, you see this idea of some mixture between humans and animals. And this is a picture of one of the X-Men characters, the Beast. So this idea has always existed, that somehow we could have this chimera between humans and animals. Now, of course, the concept of xenotransplantation extends about 300 years. And it was initially started by transfusing animal blood into humans. And this is a picture from 1705. You can see a goat being cross-transfused into a human. And of course, you would all realize that that would never be practical, but this concept existed. But really, the actual organ transplantation between animals and humans can be credited to three pioneers in this area. One is Keith Reemtsma, who in 1963 actually did 13 kidney transplants from chimpanzee into the humans. And again, the results were not spectacular, but at least one of those patients survived for about 9 months with a functioning kidney. And the cause of death for that patient was not thought to be related to the kidney after 9 months. And in fact, that was one of the reasons that this gentleman, James Hardy, who was one of the pioneers in lung transplantation, human lung transplantation, got interested into the concept of utilizing human xenotransplantation into humans. And in 1964, he visited Keith Reemtsma, learned how he had set up his program in Mississippi, and subsequently went back, in Tulane University, and subsequently he went back to the University of Mississippi and did the first human transplantation using a chimpanzee heart. And that patient actually died several hours after the operation. And even though James Hardy was very well known for doing the first human lung transplantation, he became scrutinized significantly for this process. The third one is really the very famous one. Actually had a lot of influence on my own career choice to become a heart transplant surgeon, was Dr. Leonard Bailey at Loma Linda Hospital, who in 1983 transplanted a baboon heart into a baby, which came to be known as baby Faye, who had hypoplastic left heart syndrome. And that baby survived for about 20 days and subsequently died. Again, this is in 1983, where a lot of the barriers to transplantation and a lot of the immunosuppression still was largely ununderstood. But this kind of like gives you the number of clinical xenotransplantation worldwide that started in 1964 with Hardy, as I mentioned, and in fact in 2022, briefly we're going to review what you all may have heard with Dr. Griffith at University of Maryland, transplanting a pig heart into a live human who survived approximately 2 months. But again, one of the interesting things about this is you can see that really initially a lot of the xenotransplantation was concentrated on using some sort of a primate. The thought being that because primates are, from an evolutionary standpoint, closest to humans, that their genetic makeup would make better match between the donor and the recipient for long-term survival. However, in the more recent years, as you can see, the pig has become really the donor of choice. And why is that? Again, I think if you compare the pig to the baboon, there are a lot of advantages that the pig have. First is, the number of pigs available in the world compared to the number of baboons in the world. Second is the fact that the pigs have very good breeding potential. Their gestational period is shorter. The period of time that they become mature enough to be able to reproduce is much shorter in the baboon, about 3 to 5 years, in the pig about 4 to 8 months. And the number of offsprings that they can generate, also they can grow much larger to the point that they can actually reach a size that would be reasonable for human transplantation. And again, there are a lot of other attributes to the pig. More importantly, I think, as we will discuss later, is the idea that you can actually take the pig and genetically modify it, and we will discuss some of that. So from an anatomic perspective, I think you may have heard that people keep saying that, well, you know, the pig is very similar to the human and therefore it's good. Yeah, although physiologically the pig heart functions very much like the human heart, there are some anatomical differences. Although these anatomical differences are not a hurdle to clinical transplantation. So first and foremost, you know, again, if you look at the axis of the heart for the human and you look at the apex, is very much diagonal, whereas in the pig, because they are quadrupedal, it's more like a perpendicular type axis. As a result of this, there are some gross anatomical differences. So for example, if you look at the pig heart, interestingly, the pig heart is more shaped like a human Valentine, you know, the same kind of thing that on February 14th on Valentine's Day, everybody starts getting excited about, than the human heart. So the LAD actually points more towards the right than towards the apex as it does in the humans. In addition to that, in the pig, the atrial appendages are much more prominent compared to the human. If you look at the back of the pig heart, again, because of the quadrupedal stance of the animal, you can see that, for example, in this picture, that the inferior vena cava and the superior vena cava come together more as a right angle, whereas, as you all know, in the human, it is more of a straighter line. And again, as I mentioned to you, so this is kind of gives you the human heart. You can see that the axis of the inferior vena cava and the superior vena cava, all of which you've seen in the operating room on a daily basis. And again, in the pig heart, that's different. Also, interestingly, in the pig heart, there's a large azygous vein that drains into the coronary sinus, as opposed to the human that it drains into the superior vena cava. So when you go to procure this heart, you always need to ligate that large azygous vein that drains into the coronary sinus. Now, if you kind of slice these hearts open and look at it again anatomically, here the pig heart and here the human heart, you can see very interestingly that the pig heart is much more coarser compared to the human heart that has all these trabeculations. And also in this picture, you can look at the cavity of the left ventricle, and you look at the way that the muscles of the pig are relative to the muscles of the human. You can see that there's significant differences anatomically and pathologically, and the pig heart is significantly thicker, specifically in the left ventricle. Now, as I said before, despite these anatomical differences, physiologically, the pig heart performs very much similar to the human heart. So really, the barriers for transplantation have always really been in terms of rejection, whether that's the pig heart into the chimpanzee or the baboon, or the pig heart into the human. And if you kind of look at this, there's several levels that we have learned from extensive animal experimentation that have been done over the last 2 decades. The first one is this concept of hyperacute rejection, where we all have preformed antibodies against the carbohydrate residues that are in the animals. And this is very much kind of like ABO blood incompatibility. It's the same reason why you can't transplant a patient who has a blood type A into a patient who's a blood type B, because these residual carbohydrates will lead to hyperacute rejection from these preformed antibodies. But then again, what else have we learned from animal studies is that many times, even if you can get over the hyperacute rejection, some of the things that we see that cause early graft failure are related to coagulation and thrombosis in the small vessels of the organ, a term that you may have heard as microangiopathic thrombosis. And finally, I think if we achieve long-term survival, if we overcome the hyperacute rejection and this coagulation, the long-term aspects of rejection need to be addressed. And I will talk a little bit about this at a later slide. And finally, one of the things that we have learned from these animal experiments is that the pig organs, specifically the heart, grows very rapidly within the chest. And in fact, many of the early experience with xenotransplantation from the pig to the baboon, the problem was that these hearts would grow so fast that they would actually outgrow the size of the chest of the baboon. And again, we'll talk about this a little bit later. So what is it that we can do, and why is it that this field has become so interesting and exciting suddenly after about 2 decades of research, where, as you know, the prominent, Dr. Norman Shumway, father of heart transplantation, a quote that he used to say, and many people repeat it all the time, is that xenotransplantation is the future of transplantation and always will remain so, meaning that the barriers that I just mentioned to you can never be overcome in order for us to be able to clinically do this. So what really has, of course, changed this entire world is the ability to genetically modify the pig. And again, in the 1990s, you may have heard about the sheep Dolly that was cloned, and this same technology is now being applied for a genetic modification of the pig. And this slide kind of gives you a little bit of a background of what that entails. And that basically means that a somatic cell, in this case, a fibroblast, is taken out of a pig, and it's and that somatic cell undergoes specific gene modifications. In this case, what the picture is showing is that the alpha-gal gene, which is the enzyme that produces the alpha-gal, one of the major carbohydrates that's been responsible for hyperacute rejection, is removed from this sequence. The nucleus of this cell is removed, and it's transferred into a pig egg that has been enucleated. So the nucleus of this cell has been removed. This new genetic material is added to this cell by an injection, and then activation, believe it or not, with an electrical impulse, causes this genetic material to move into the cytoplasm of the cell, of the egg. The egg then undergoes several mitotic divisions, and then when it reaches the blastocyst stage, it is actually implanted into a surrogate mother that is ready for gestation. And this surrogate mother then gives rise to a pig that now does not any longer express the alpha-gal epitope. So this is really what the process is. And what really has now changed is that besides knocking out one gene, the capability exists to knock out additional genes that code for 2 other minor carbohydrates that we can reject. But more importantly, I think, again, the last decade has seen the concept of being able to edit the genes by putting in genes, the knock-in genes, that would address some of the pathophysiology that we have seen in animal experimentation, specifically genes that would inhibit the complement activations, genes that would modulate the coagulation pathway so microangiopathic thrombosis would not occur, and also genes that would modulate the inflammatory phase. So again, we would reduce the potential for rejection. And by now being able to create this genetically modified pig, we can now think about the potential for transplantation of these organs into humans. Now, what are some of these genes? As I alluded to it earlier, the alpha-gal is the major gene that encodes the major carbohydrate, but there are 2 additional minor carbohydrates. These can all be knocked out. And then there are a variety of genes that have been experimented in. Again, we're not going to go into the details, but all of these genes are genes that modulate both the inflammatory phase of during transplantation, as well as the thrombotic and the coagulation pathway and the complement induction pathway. All of these genes have been in various forms been inserted into the pig genome, utilizing vectors with a promoter that would allow the expression of these genes once they have been transferred to the pig. So one of the interesting things about this is that, yes, despite all these modulations of genes that have been made, and what we believe that now we can actually get rid of the hyperacute rejection, which was one of the major barriers to xenotransplantation by creating this triple knockout gene, is that there's still concern that both acute antibody-mediated rejection as well as chronic antibody-mediated rejection may still occur. In fact, a lot of people who are in this field believe that from regular transplantation and the experience that we have from transplantation, we are probably very capable of controlling cellular-mediated rejection. But antibody-mediated rejection, both in the acute and the chronic phase, still needs a lot of work. And again, as you kind of look at how this is going to be clinically rolled out in the future, you're going to see that we, at this point at least, we believe that these patients would need to be treated with a very different regimen that you see now in organ transplantation. And this different regimen really is focused on treating the concern, or at least the concern for antibody-mediated rejection. So a lot of the protocols that we're going to be looking at for human transplantation would include desensitization protocols that we now utilize for human transplantation, including plasmapheresis. Complement blockade chronically has been a big issue in xenotransplantation, so drugs that inhibit complement will probably be part of the armamentarium in clinical transplantation, something that you don't see currently in clinical application of allograft transplantation. People have talked about utilizing these experimental drugs that actually cleave IgG to prevent antibody-mediated rejection. And then, again, you see a host of drugs that are all targeting the antibody-mediated rejection that we, at this point, we're not using in human transplantation, including some drugs that are targeting the cytokine production, in this case, the IS-6 blockade with tocilizumab or clazizumab. So, having said that, having kind of given you a background of some of the concerns that we have, what do we know from animal studies? And again, I think that this really, the credit goes to the Munich group, who has been extremely crucial in our understanding of what happens during xenotransplantation when you look at the pig to the baboon model. So the Munich group actually has done extensive experimental work in this field, and very interesting, as you can see here, the only the mutations, the gene mutations or the genetic modifications that they utilize in these experiments are only a 3-gene pig, which is the galactose, the alpha-gal epitope, plus some 2 genes being inserted that would modify both the inflammatory phase and also thrombomodulin in terms of modulating the microangiopathic thrombosis that I talked about. So they basically published their data in Nature recently in 3 groups. In group 1, where they had 4 animals, basically what they did is that they were utilizing standard preservation solutions for this transplantation, either the HTK or the UW solution. As you can see in this group 1, none of the animals survived even the 30 days. And in fact, many of the animals can never be separated from cardiopulmonary bypass due to graft failure, xenograft failure. And as a result of this, the Munich group was really instrumental in starting to look at preserving the pig heart in a machine with the STEEN solution. And nowadays, this really has become dogma that in order to be able to do these transplantation, you need to actually take the pig heart, put it in this ex vivo machine for perfusion with the STEEN solution, and then transplanting them. And what this Munich group has demonstrated is that they were able to get rid of this primary graft xenograft failure that you would see not being able to separate the patient, the animal from cardiopulmonary bypass. And in their experiment with 4 animals, they were able to successfully get the patients or the baboons off the machine. However, again, up to 30 days, many of these animals, the 4 animals, started to die. And the reason that they started to die was because of what you can see here in the gross histopathology, showing that, in fact, one of the things that has become of great concern, and I'm going to talk about this again later in the human transplant, is that the pig heart, specifically the left ventricle, hypertrophies very rapidly. And in order to be able to make this work, what they had to do was introduce specific means of trying to reduce this hypertrophic response that we see in the pig heart. In this case, in group 3, they basically started introducing very stringent criteria for managing the blood pressure of the baboon. And they also added a derivative of sirolimus, which is known to modify hypertrophy. And interestingly, by utilizing this protocol, they were actually able to extend the life of these transplants to 200 days. And the Munich group recently then updated their data by utilizing this modified protocol where they manage hypertrophy of the left ventricle. And as you can see in these gross pathological features, in the recent publication, actually they were able to extend both to 100 days survival, and in 2 cases up to 200 days survival, suggesting that in fact perhaps we are ready for clinical transplantation. Interestingly, in this group of animal transplants that they did, you can see that 2 of the animals died within a month or so. And this was really attributed to the concern about transmission of CMV virus from the pig into the baboon. And they attributed this rejection as related to CMV infection. And again, this comes into play once we want to start thinking about human transplantation. So interestingly, all the data that we have to date has never been on the 10 genetically modified pig. All the data that we have either from the United States or from Germany and Europe is really modifications that have included probably 3 genes. So the only experience that we have with the 10 gene modifications that I mentioned to you earlier, which is 3 carbohydrate knockouts, the growth hormone knockout, which evolved as a result of what I showed you earlier, which is the growth of the pig heart in the baboon and the hypertrophy of the baboon, and then the 6 genes that are introduced to modify inflammation, thrombogenesis, and complement activation. The first real experience we have with that is the human transplantation that occurred in the University of Maryland by Dr. Griffith in this gentleman, Mr. Bennett. As I told you earlier, Mr. Bennett died after 60 days. In this publication, it's very interesting because, again, if you kind of look at the data that was published in the New England Journal of Medicine, you can see that somewhere around day 30, we start seeing an increase in the troponin, suggesting that there's ongoing damage occurring to the myocardium at some level in this heart. In addition to that, if you look at the relative MFI, meaning that formation of de novo antibodies to this heart, it almost seems that it parallels the same increase in troponin that we see, both in terms of IgG and in terms of IgM. You can see a significant rise in titers of these antibodies to the pig heart. On the bottom part, they actually published their study on transthoracic echocardiograms that they were getting pretty much on a daily basis. And again, you can see around day 30 or 40 that there's a significant increase in the LV posterior wall thickness. And relative preservation of the ejection fraction and decrement in the strain. Again, suggesting that there is increase in the thickness of the LV wall cavity, the same concern that we had seen earlier with the baboon experimentation that the Munich group was reporting, suggesting that perhaps some degree of myocardial injury is occurring as a result of antibody-mediated rejection, and perhaps some of that is causing this increase in in overall hypertrophy or thickness of the left ventricular cavity. And of course, this is very concerning. And of course, Mr. Bennett died around day 60. And interestingly, one of the things that you may have seen in the news is that they were referring to the fact that they were concerned that there may have been some CMV transmitted from the donor pig to Mr. Bennett. And as I showed you earlier, CMV infection is thought to be a very big deal in terms of the animal experiments, inducing an inflammatory response that may eventually lead to this rejection that perhaps they were seeing in this gentleman. So where do we stand at NYU? So up to now, I kind of gave you a little bit of a background of what we've seen both in animal studies from Europe and the United States, and also human studies. When we started kind of looking at this technology, we thought that the best way to address this was not to study it in a live human and not to study it in the primate, because a lot of the information that we receive from the primate cannot really be translated into the human, but instead create this intermediary where you would take a patient who is normally considered dead because they're brain dead, and these individuals already are not suitable for organ donation because of one reason or another, for example, age. None of the organs are adequate for transplantation, and take these individuals and see if we can take these brain dead decedent individuals and do a transplantation in them. Let me see if this video plays. So I'm sorry that this video doesn't show, unfortunately, but basically what we did at NYU is that in September and November of 2021, we transplanted 2 kidneys in the groin of 2 decedents, and basically demonstrated that these kidneys are functional if they are transplanted in an ex vivo fashion and the human body supporting them. And based on that success, we then thought that perhaps we are actually ready to do a human transplant in the same model, where we took 2 brain dead humans and we would do an actual orthotopic transplantation of a pig heart into the human and watch these humans for 72 hours in a makeshift operating room. And the idea was that we would do an orthotopic transplantation of these humans, of the pig heart, and over this 72 hours really monitor the function of the heart, as well as any evidence of rejection, and also, more importantly, I should say, any evidence of potential transmission of infectious viruses from the pig into the human. So we created this operating room with a bypass machine and performed our operation in this OR, and then converted this OR into an ICU where we could observe these patients for 72 hours with intensivists and a nursing team that would take care of these people. And it is very unfortunate that I cannot play either one of these videos, so you have to take my word for it. In this first one, if you see after the pig was transplanted into this decedent, that the function of the heart is absolutely amazing on 5 mics of dobutamine. And this is our echocardiogram. Again, unfortunately, for some reason, it doesn't show over Zoom, but basically shows that echocardiographically on day 1, 2, and 3, which was the period of time that we observed these patients, the function of the heart is amazing. And there's no decrement in systolic or diastolic function. So this slide basically is a very complicated slide, but shows what was happening to the patient's blood pressure, hemodynamics, cardiac output and vasopressor requirements. And what I can tell you, although it's a very, very busy slide, is that in the first decedent, for the first 40 hours, everything was okay, but we started seeing significant drops in cardiac output and blood pressure after about 40 hours into this, and requirement of increased pressure doses to maintain this individual. On the other hand, on the second patient, we really didn't see any of this. In fact, the patient had an adequate cardiac output, adequate blood pressure on very low dose of dobutamine throughout the 66 hours that we observed this patient. Now, why was that the case? The real reason was that when we received the pig heart for the first patient, there was a significantly size discrepancy between the heart and of the donor into the recipient. And here you can see the X-ray. This is the patient's own heart, and this is the heart that we transplanted. And I can tell you that when we got the heart, I thought that the heart was way too small for this recipient. And I think that in this, the reason that after several hours we needed to increase the inotropic support and pressor support was because this heart was too small to physiologically maintain the patient. On the other hand, in the second patient, you can see that the size of the heart was much better. In fact, you could see that visually. And this heart went on to support the patient completely over the 66 hours that we continued to do this experiment. Now, interestingly, after the observation period, of course, we took the hearts out and we sliced them and we looked at them. There was some degree of hemorrhage in the LV outflow tract, both in recipient 1 and recipient 2. In recipient 2, this much reduced. I think that this is what we see with ischemia reperfusion injury, that we always see it clinically, except that clinically we never take a heart out in 3 days and look at it. And it's possible that this could be mitigated to some extent by that machine perfusion technique and machine perfusion transplantation. When we did our transplantation of these two individuals, we did not use machine perfusion. We did it like we do a standard transplant, where you preserve the heart with a, in our case, UW solution, and you transport the heart in cold storage, static storage. We did not use the machine perfusion that the Munich group suggested had to be used. And again, if you look at the gross pathology, though, you don't see any significant other problems, both in recipient 1 and in recipient 2. And again, if we kind of like look at this histologically, the myocytes were intact in both recipients. There were some areas that we saw some focal myocardial hemorrhage, but this is probably, again, related to the reperfusion injury. But more importantly, we did not see any evidence of either cellular rejection or antibody-mediated rejection over a 3-day period. So what did we learn from the experience at NYU? And again, I apologize that I didn't present you the entire data from this xenotransplantation, because I'm supposed to be presenting it in 3 days at the International Society of Heart-Lung Transplantation. But suffice it to say that, in our experience, we showed that, in fact, xenotransplantation into the human from pig is feasible. It technically can be done. It needs some modifications. We do know that it can hemodynamically support the normal human physiology, but appropriate sizing is very, very important. In the first case, as I showed you, the size was smaller. And the problem is, again, we're not at the stage that we have these pigs available at all different sizes at the present time. We're still in the experimental phase, and we had to take whatever pig heart was available to us. This is something that obviously is modifiable for future. Other things that we learned is that what we learned in the short term is that there was no evidence of hyperacute rejection, no evidence of cellular, but more importantly, antibody-mediated rejection. And the data I did not show you was that we were unable to show that there was any transmission of endogenous porcine viruses from the pig to the human. And this included any potential CMV, which was never detected in the pig, and it was never detected in the human recipient either. So obviously, because this was a very short-term experience, there's much more that we need to learn. Now, where do we go from here? Again, I think the best data that we have is still from animal xenotransplant models. And in the baboon, the kidneys have survived up to 500 days, to close to 2 years. And in the heart, they have survived up to about 200 days, or you should say close to about 6 months. So what do we need here to be able to make that transition to humans? Do we need more data on the primate? Do we need to do a longer evaluation in a decedent model like we did at NYU? Instead of doing 72 hours, do we learn more if we go to 1 week? Do we learn more if we go to 1 month? And the answer to that is not known, except that in the decedent model, it's going to be very costly, as is in the primate model, to maintain these for a longer period of time to learn more. Or are we at this point in time ready to just go into the humans as a proof of concept based on the fact that we have now been able to achieve long-term survival in the baboons? I can tell you that at least in the United States, I don't think that the FDA is ready for human trials. And the FDA at this point is still suggesting that we need additional primate experimental data before we can consider this into the human. Now, of course, again, as proof of concept, the reason people are concerned about it is that we still don't have a lot of data. I mean, we don't know what the longevity of these xenografts are going to be in the human. We don't know what the adaptive immune response is going to do to the pig potential neoantigens, both cellular and antibody-mediated rejection. And the long-term safety of these genetic constructs are largely unknown. And in some cases, we don't still know if these genes that are being inserted into the pig heart, at what level they're actually being expressed. We have some histological documentation that they are getting expressed, but we don't know how much expression is occurring, and if that amount of expression is enough to mediate all the pathological concerns that we have. So we don't know a lot of these things. Of course, there's some ethical concerns, which patient should receive these hearts, and there's some public health concerns, is there a potential for a zoonotic transmission of viruses from the pig to the human? And again, I think people are very hyper aware of these situations because of the recent COVID infection and pandemic, and whether or not there are some latent viruses that we don't know about that could be transmitted to the human. So interestingly, Dr. Loeb, who is now at the University of Miami, and I have a lot of respect for him, he actually wrote an editorial when the first human transplant was done, suggesting that there is no conceivable patient population who would seriously need to be considered for heart transplantation with the xenograft. And again, I respectfully disagree with this comment, because I do believe that there are a group of these that can be considered. So very interestingly, I put this slide in, but I won't talk about it too much, is that, in cardiac surgery, we are very tolerant of being heroic to save the life of a young patient who's going to die. But if we think that they have a greater than 50% chance of survival, we will do whatever it takes to try to save the patient's life. But what we don't really pay attention to is, what we call sins of omission, right? Some patient presents to the transplant service. The transplant service says, well, you're not a candidate for transplant. And the surgeons say, oh, no, this guy is not a transplant candidate. And you never hear about this patient going home and dying, right? They're nowhere to be seen by the surgeons. And it seems that, we're okay with that, right? We didn't give them a chance. So what I'm saying is that there are a group of patients, unlike what Dr. Lobe had written, that I think would probably benefit from transplantation, or at least be candidates for xenotransplantation, who are not already. So who could these patients be? These are patients with severe biventricular failure who are not amenable to current LVAD therapy. And in fact, the TAH, as much as the total artificial heart like it, is still not a clinically reality practical approach to saving patients' life. So other patients, perhaps those who have a short life expectancy, perhaps less than a year, either due to recent cancer or those who have restrictive cardiomyopathy who are not a transplant candidate, either due to age or let's see, AL, amyloid that's not treated. Patients who have severe allograft rejection from chronic, allograft failure from chronic rejection who need retransplantation, and it's very difficult to get these patients retransplanted. How about patients who are highly sensitized? They have 100% PRA. You can never get these patients transplanted, but we are actually accumulating data that these patients perhaps do not have antibodies against a pig heart as opposed to a human heart. And finally, again, there are certainly a segment of pediatric patients who have a 25% mortality on the wait list because even as human hearts, adult hearts are rare, pediatric hearts are even much, much more rare. So can we use it as a bridge to transplantation in the pediatric world? So with that, I thank you guys. This is our xenotransplant team at NYU when we did that procedure. Of course, it was during the COVID pandemic, so everybody is masked. And I think at this point, Matteo, I'm going to end and I'm going to ask if you have any questions.
Thank you, Dr. Moazami. That was a great talk, and thank you for sharing your experience and the presentation. And again, I want to congratulate you for your work because, I mean, it's not easy to be a pioneer in a field, and you really are. And I think it's a very important let's say, untreated need, because I mean, I was very surprised about the fact that in the United States, you only transplantate 1/3 of the patients requiring heart transplantation, because I mean, you have huge transplant centers and you actually transplantate way bigger volumes that we do in Germany. So I wonder how is that percentage of the population in Germany. So I think we do have this necessity even more than you guys do in the United States. I do have a couple of questions. I don't know if there are some questions in the from the people in the audience. Otherwise, I can my question. Well, I mean, my question is like, I mean, this is an ongoing development, as you told us, but like I still have to work like for 40 years. So do you think I'm gonna see it like in real routine clinical practice during my, let's say, work life? When do you think this is gonna really happen, as a routine?
Yeah. So I think that there is difference between the kidney and the heart, and I really believe that the kidney xenotransplant clinical trial will probably happen in the next 2 to 3 years. But I think that we may be still very far away from the heart. As I said, there's still a lot of concerns with the heart. One is, obviously we don't have a back out strategy with the heart, right? If the heart starts failing, it probably means that's lethal and the patient is going to die, as opposed to the kidney that they still can back up dialysis on these patients. The second reason is that, there's still some concern about some of the longer term rejections. And I'm not sure 100% that we understand if that left ventricular hypertrophy that has been seen in animal models is going to be mitigated in the humans. And when I saw the data from the first human transplant about LV hypertrophy that occurred, it does concern me, because I'm not sure we still have all the tools that we understand. But having said that, I really don't think that we are going to continue to learn anything different from animals. I think that we have reached the plateau of what we can learn from transplanting pig hearts into baboons. And baboons, are not easy animals to maintain. And there are a lot of therapies that we can do on the human, for example, plasmapheresis, that you can't do on a baboon. So I think in answer to your question, we need to cross the threshold to say that we are ready for a clinical trial, because the only way that we can learn is from a clinical trial. And we need to then think that who are going to be the people who are going to be in this clinical trial, who are willing to undergo this clinical trial. And I think that that population exists. I think that there are a large number of patients that we all consider not candidates for transplantation. Perhaps one of the biggest barrier being age, right? Let's say you're in your mid-70s and you have a pathology that cannot be treated at the present day with an LVAD, right? You have biventricular problem. So amyloid disease is a classic, right? It's a restrictive cardiomyopathy in a patient who is 73 or 74, who has no options, no mechanical circulatory support option, no transplant option. Is that patient an appropriate candidate for a trial like this? So I think that we can identify patients who will fit into that category. And I think that what you will see in the next 4 years of your career is this push by clinicians that we need to make that jump, that we are ready for proof of concept. And in order to know more about this, the only way to do it is to do a clinical trial. So again, if you have an appropriate candidate who's going to die within 6 months to a year, and they're willing to undergo this procedure with appropriate consenting, I think we can identify those patients. I kind of put down some of those, like even patients with cancer, right? Someone who's had breast cancer who was treated a year ago, we would never consider them for transplantation. But if they're going to die from heart failure, maybe that patient is an appropriate candidate if that's what they want. Okay.
Okay, yeah, thank you. That was a good answer. There is a question in the chat from one of my colleagues. First of all, he thanks you for the presentation, and then he has two questions. The first one is, are there, in your opinion, any patient-related factors that make them a better fit for xenotransplantation than others? For example, the patient being bigger. And the second question is, are there any recipient-specific gene modifications that you are looking into in order to make the donor heart less likely to be rejected?
So thank you for your comment and the answers to your questions. That I don't think that there's any specific characteristics of the recipient patient, except that we have the transplanted patient that would survive the operation and the so a patient that doesn't have too many comorbidities. Like, for example, the patient that was transplanted at Maryland was on ECMO for 30 days or maybe even longer for that. He was on his back. He had some pressure ulcers. He had a lot of problems. So I think that in order for us to see if this technology works or not, we can't put it into patients who are at their death and try to do it as rescue therapy. This has to be implanted in a patient who is otherwise would be a suitable candidate for transplant, but has some contraindication, right? Their organs have to be working. They have to be able to get out of bed and walk. They can't be debilitated. They can't be malnutrition. So I think that is the key in order to give this technology a chance to be evaluated, fairly. And then the question for your second question is that I don't think that we're there yet, that we can make genetic modifications in the recipient. Again, there are a lot of ethical challenges to that. The technology exists for sure, there's no doubt. But I don't think that we're there that we can make genetic modifications of humans. I think maybe you will see that with other conditions, but not for transplant. But having said that, I think that we can learn a tremendous amount from these genetically modified pig hearts, because if you can modify 10 genes, why can't you modify 20 genes? So if you were kind of thinking about this in a futuristic manner, it is possible that a day comes that you will be able to create a pig that is genetically closer to the human recipient that's going to be. I don't think we're there yet, because I think that, again, these genetic manipulations, at least in the United States, are viewed by the FDA as a drug. So every time you change one gene, that's a new drug. And the FDA is very strict about these things. And also, if you start modifying too many genes, the genetic may become unstable. So I don't think we're there yet. I think At this stage, based on experimental data, we have this 10 gene modified pig. And realistically, we need to understand at this point if this is feasible. If this becomes feasible, then it opens the door for many, many, many other potential possibilities.
Okay. Well, if there are no questions, I do have one other question. Like, how does, I mean, you are in a experimental phase of the whole thing, but I still have a question. Like, how does it work? Like, okay, you decide you're going to do the transplantation today. Like, you order the pig. Like, how much in advance you have to order? Let's say order a pig, and where is the pig? And like, when do you sacrifice the pig? Like, just before you start a transplantation, or how does it work? Like,
right. So these pigs are, are being generated at a company. There are actually several of these companies. I think in Germany, there's also a company as well dedicated to this. So the pigs are modified and grown in these companies, which is off-site. And at this, and again, the process that I showed you of how this occurs with the fusion of the nuclear material and the growth of it, it's not easy and it's not very efficient. So I don't know exactly what their efficiency is, but I can tell you if they do that procedure in 10 pigs, maybe one of them would be able to bear a piglet that would be able to express those genes. So we're not at a point that we're still very, very efficient. So in our case, we are basically at this point at the mercy of what pigs are available and what size pigs they're going to be available to be able to do this clinically. So I think if we ever get to a clinical trial, that efforts has to be made to make sure that many different pigs of many different sizes are available for this transplantation to occur. And again, that's not impossible. It's just that we're not there yet. We're going to get there at some point. That's not a limitation. That's not a barrier, right? And then how do we do it? You're absolutely right. The way we did it is that we flew a team down to that pig farm. We actually did the pig heart harvest right there, put the heart in a bucket, put it in cold storage. And as our team was flying back, we opened the chest and we went on bypass. And when the heart arrived at the operating room, we did the transplant. So we did it very much like you do now with clinical transplantation. In the Maryland case, it was different. In the Maryland case, they actually took the pig to Maryland. They did the organ harvest at University of Maryland, and they did the transplant right there. We don't have that capacity. I mean, we can't bring a pig into our hospital, So I think the model would be that we would do what we do now clinically with organ transplantation, go to a distance and bring it back. But of course, in this case, everything can be done electively, right? It doesn't have to be a 2 a.m. case.
Yeah. Okay, there is a last question in the chat again. Do you see any learnings from the xenotransplantation that might be carried over to the allotransplantation? Like, did we learn something from xenotransplantation that we can use to improve allotransplantation?
Yeah, I mean, I think that one of the issues in allotransplantation that we really don't have a lot of grasp on is on antibody-mediated rejection, chronic antibody-mediated rejection, and how to deal specifically with sensitized patients who have PRAs in the 90 percentile. So I think that, some of the technology and some of the immunosuppressions and some of the new drugs that are now not utilized in humans would potentially be translated into human treatment. So I think we will learn a lot about AMR in the pigs or in this model of xenotransplantation. Many of that may hopefully be translated then into the humans.
All right, thank you. Well, I don't know if there are any other questions. Okay, seems to there are not any questions in the chat or here. Okay, good. Yeah, thank you again. Oh, by the way, before I forget it, I have to apologize my boss or department's head because he's in a parallel commitment. He has parallel meeting with the other department heads in our hospital, so he apologizes and yeah, he sends you best regards and maybe the next time.
No problem, no problem. I'm glad. Thank you for having me. I hope it was a good session for all of you.
Yeah, thank you. Thank you. Bye-bye.